Hello, everybody, and welcome to the Petrie-Flom Center's second ever live stream. This is our event, Debt, Dignity, and Healthcare, Guaranteeing Health Rights and Universal Health Coverage. We have an exciting program for you, but before I turn it over to our Senior Fellow in Global Health Rights, Ali Yamin, just a few housekeeping things. This is one of our first Zooms, so we apologize, but due to some technical challenges, we are not taking questions through the Zoom function. I know that Zoom gives you the option to raise your hand, but please don't use it. We will not be monitoring that. If you do have a question, we encourage you to join us in conversation on Twitter using the hashtag #DebtDignityHealth. We will be monitoring that hashtag, and our moderators will be pulling questions that are posted to share with our speakers. With that, I am excited to turn it over to our Senior Fellow, Alicia Yamin.
Good morning, everybody, and welcome to the live stream event on debt, dignity, and universal health care. We're really very delighted that we've been able to pull this together, even though we couldn't be together in person. And for many people around the globe who are interested in this subject, we're very grateful that you could join us. The original idea of pulling two quite separate panels together, one on detentions in facilities, largely in sub-Saharan Africa and in low resource contexts, and the other on debt, private debt in the United States, was to really try to reimagine the way global health issues are often talked about and look at not just denouncing terrible, scandalous things in one context, but what insights we can gain from the dynamics that drive these violations across contexts, and also distinguish what is different, what are similar dynamics in terms of financing and priority setting and the exclusion of the least the most vulnerable and the least well-off members of society, but also distinguish different capacities for response and effects on people's lives in different contexts. So I'm very, very pleased to welcome Rob Yates, our first keynote speaker, who is the Director of Global Health at Chatham House, which many of you may already be deeply familiar with. And they have done a series of studies on detention of patients in facilities in a number of countries. So we'll first hear from him. I will then ask him a few questions, and to reiterate what Carmel said, we won't be accepting questions live, but please do feel free to share tweets and send them to us. And then we'll move to the second panel. Thank you.
Good morning. Greetings from my study in southwest London, which is masquerading as the Centre for Universal Health at Chatham House, the think tank in London. And I'd like to talk to you for about the next half an hour about a really quite shocking phenomenon, and that is of people being locked up, detained in hospitals against their will because basically they can't pay their hospital bills. So I'll be talking about that in the context of health and human rights. So I have a few slides, and I'm going to do something very daring, which is even to sort of try and introduce a video in the middle of my slides. So please bear with me. I haven't done this before, so this might all crash in flames, but we'll have a go. So I'd like to start off with the slides and just check that you're seeing the slides. So can someone confirm that you're seeing my slides?
Yes, you're seeing your slides.
Great, that's fantastic. I thought I'd double check rather than get halfway through it and everyone's looking at a blank screen. So just to explain that, I started getting interested in this issue through my work looking at the impact of healthcare user fees. I was posted in 2000 to the government of Uganda, and 10 days before the presidential elections, President Museveni scrapped all healthcare user fees throughout the entire health system. And we saw a dramatic increase in the utilization of services, which was predominantly benefiting the poor. And this was, sort of quite a moment in my career when I realized how wrong health financing policy was in encouraging countries to introduce user fees. And really since that day, March the 1st, 2001, I've been studying health financing and the impacts of different health financing reforms on the utilization of healthcare across the world. So I was very sort of interested in this issue of healthcare user fees and the impact it was having. But it was in 2005 that I was first made aware of this phenomenon of people literally being locked up in hospitals because they couldn't pay their bills. And a quite astonishing report that I'd very much recommend you read, produced by Human Rights Watch, about the impact in Burundi of this practice. And basically this report showing that the hospitals in Burundi at that time were largely sort of functioning as debtors' prisons. Sort of the people were racking up big bills. Sort of often it was associated with women having cesarean sections, being presented with a bill for $100, $200 or so, not being able to pay, and in effect being held hostage until their families came up with the bill, with the money. And this was happening at quite a large scale in Burundi, as the report showed. And people being detained for weeks, months. One person they found had been actually detained for a whole year. And these quite sort of shocking testimonies. Here's one of a young woman and her baby. And I think, this is, an actual genuine photo of this poor girl, saying that she had come to hospital because she needed a cesarean. When she got the bill, the doctor said, since you have not paid, we will keep you here. And life being difficult. They're often hungry. And this being a feature of a number of these cases of people being denied food, denied medical treatment, and in effect being abused whilst they're being held hostage in hospital. Now, this had a dramatic impact in Burundi. It was such a powerful report, and it was brought to the attention of the president. And to his credit, he was horrified to find this out. He wasn't aware that this was happening. And the president took dramatic action. Just before Christmas, he released all the pregnant women and children from hospital in this big sort of gesture, but was also wise enough to realize that there was a systemic problem, and that if he didn't change the financing regulations, that the hospitals were just going to fill up again. So he also launched a program of free healthcare for pregnant women and children under 6. And this had an immediate dramatic impact on the health sector. Hopefully you can see this in this slide, that whereas before the policy change, only about 1 in 5 babies were being born in a health unit in Burundi. Once the president, A, scrapped user fees, and B, banned the medical detentions, because obviously no need for detentions if there's no bill to be paid, you have this rapid escalation in babies being born in health units. And in fact, by 2011, this had reached 3/4 of babies were born in health units. And then, interestingly, there was a demographic and health survey done in 2005 and another one done in 2010, and showed that there was a reduction in both child mortality and infant mortality of 43% over that period. Now, one isn't just going to attribute that to these reforms, but you can see that health-seeking behaviour was changing, and people were much more inclined to go to a health facility when they knew they weren't going to be detained there. So that was a good news story, and I think a good example of pressure being applied to a government to change this policy. But then I was seeing these other stories coming up. This one in Kenya, this is, if you Google this, you'll find this was a Guardian story of 2009 of Kenyan mothers being too poor to pay for their treatment. And I think this particular woman had been locked up for 3 months in Kenya because she couldn't pay her bills. And then particularly beginning to see some countries where this was very, very prevalent. By this time, I was now getting Google alerts on this topic. I think, just using the alerts, detained hospital bills, something like that. And about sort of once or twice a week, I was getting these stories, but seeing that it was particularly prevalent in some countries. And one country was the Democratic Republic of Congo, where we were seeing this at quite a scale, and it even being reported in the UK Daily Mail, quite a right-wing publication. So, this was even shocking the likes of the Daily Mail, that women and babies were being locked up in a large scale in Congo because of this. And this is where I'm going to hope to show you a video that became available at this time. I think it was AFP was sort of showing this video. So I'll just try and switch to that now. Right, just bear with me a second. Now, is this... Oops, nope. Hang on. I knew this was going to happen. So, sorry about that. I'm going to stick with the video, and just bear with me a second. I'll try and show the video. That's actually the wrong video. So I'll stop that. So back to Zoom, share. Here we go. So this is the video.
Hospital in Kinshasa. Ornella, who became a mum at 16, has been here for 3 months, yet she's not sick. She can't return home because she can't afford to pay the bill.
I had a cesarean and I'm fine, but I've been detained here a long time. I want to go home, but I have no one to pay my bills.
And she's not the only one. Across the country, thousands of new mums are trapped in hospitals, unable to leave, unable to pay their bills. A cesarean costs between $200 and $250, a fortune here, where 3/4 of the population earn less than $1 a day. Albertine is a new mother of twins. She's already paid $170 to the hospital, but she needs to find another $30 before she can get more treatment.
With what I've already given, can you heal my wounds because it hurts?
I'm not standing before a court here.
Hospital bosses say they have no other option but to keep the women here. If they don't force their patients to pay, there will be no income whatsoever, and a third of their patients can't afford the treatment.
Several of them have not paid for their care, but they have taken drugs. Now, if we free them all, we'll be bankrupt.
And these women here are not alone. At least 20% of the women who give birth in Congolese hospitals are forced to stay on until they settle their debts. And with no state subsidies for the hospitals and no public health insurance for the poor, that figure could rise even higher.
So you can see the scale of the... Oh, right. So you can see the scale of the problem there. And I'll just show you another video, this time from Kenya. So again, this is a situation in Kenya. Now, this one is actually much more recent. This video was just sort of taking place about sort of 2 years ago, I think. So if I just click on this and that.
We are sneaking into Kenyatta National Hospital, armed with our cameras. We gained access to the heavily secured Kenyatta National Hospital and filmed secretly. These are the scenes that confronted us inside Kenya's largest hospital. Women lying down, others sitting on the floor. Some have been here for the last 2 months, others for as long as a whole year. They're being detained against their wish, and the reason they're unable to pay their hospital bills. These 20 women are suffering from birth-related complications, and some of them have been separated from their newborn babies. Susan Jane Wanjiru delivered her baby at Nairobi's Pumani Maternity Hospital, developed complications after.
Nikatengenezwa alafu nikaleta kwa hii room, nikaambia kadi yangu haiwezi nisaidia kwa saa hii. Detained at the hospitals because of non-payment of their bills.
They came in to seek healing from illnesses, and now they lie hopeless, waiting for just one thing: freedom from the hospital.
So that's the biggest teaching hospital in Nairobi only a couple of years ago, and just shows again the scale of the problem there, and those terrible conditions that those women were in. So if I now go back to the slides, so what we saw as well during this period was that this was happening at this scale, but the international health agencies were just completely turning a blind eye to this. It was around the time of that video that a very sort of glossy publication came out produced by the H4 agencies, UNAIDS, UNFPA, UNICEF, this sort of group that's listed on the bottom of the slide here, showing how they were supporting the improvement of maternity services in Congo. And I saw this photograph and actually contacted the photographer and asked him, you know, that as he was going around the hospital, paid for by these agencies to take these photos, was he aware of these medical detentions? And he said, oh yes, this was happening at quite a scale in this hospital. So, I mean, quite astonishing that, you know, this is sort of happening under all our eyes and no one really reacting to it. So we decided that this needed some more investigation. So we undertook some research and published this paper that came out about 2 years ago, an attempt to sort of try and find out the scale of this and expose how bad this practice is and you know, was and is, I'm afraid to say. And of course you can see on the photo here, you know, this was a still from the, you know, the video that the Agence France took. And the findings of our report, and this is all available online, well, first of all, needless to say, it's really quite difficult to research and quantify the scale of detentions because, in effect, this practice is illegal and hospitals don't keep statistics of the number of people that they're locking up. It's very, very hard to sort of try and find out, you know, where it's happening and at what scale. So we fully acknowledge that our studies are sort of guesswork, really, sort of based on academic articles that we found online, also media articles, you know, that we started more rigorously sort of collecting Google alerts and searching the web for stories like this, and found initially 60 media articles between 2003 and 17. But in some of these, we were getting clues. You know, for example, in the video clip there, where the reporter said that they estimated about 20% of women delivering babies in hospitals were being detained for a period of time, and then just working the numbers up, it was obvious that this wasn't, you know, a few hundred or a few thousands, but in the order of hundreds of thousands of people, you know, sort of per year. And so, but I think that the challenge is, and hopefully researchers watching might be interested in taking this further to see exactly how many we're talking about and the scale of this. But we did definitely find that this was occurring in public and private facilities, that in some countries there was a very high social acceptance. You know, this was the norm, this was an okay thing to do, that people can do this. which we might find quite shocking, but there's a real acceptance that this is the norm. As I think you saw that nurse in Congo saying, look, these people haven't paid their bills. How are we going to get paid? That's just the way it is around here. Clearly, a lot of the detentions were occurring linked to surgical procedures, emergency surgery, where someone might die at any moment, was often the sort of the cause, for the high bills and for this type of practice. And sadly, and it's documented in our report, a high amount of abuse of people detained, people being denied food, medical equipment, some really shocking stories of people being chained to urinals, being forced to work in the hospital to pay off their debts, and really shockingly, sometimes this involving sex work as well. So this, truly, truly awful situation that a number of these people, and particularly women and babies, finding themselves in. And, the question is, where is this happening? Well, it's not surprisingly sort of where there are very low levels of public financing, and going back to the Burundi story, it was the case that there was virtually no public financing going to the hospitals in Burundi at that time. And therefore there being high levels of user fees, so health workers dependent on user fees income for their wages, but also where there are weak governance systems, where the hospitals are sort of largely being told to get on with it, charge what you like, and get the money back whichever way you can. And the countries where we were finding this mostly were Nigeria, the Democratic Republic of Congo, very high number in Cameroon, but also in Kenya, Zimbabwe, to a lesser extent in Ghana, Uganda, Liberia, Haiti that we've discovered recently, even India and Indonesia as well. And not surprisingly, sort of one of the findings of this is, these detentions deter utilization of services, people delaying going in. And obviously, sort of families having to raise a lot of money, having to liquidate assets and go into debt. It's a major cause of medical impoverishment as well. But I'm sure the audience doesn't need this pointing out. This is an phenomenal abuse of human rights on so many scores. Not least people being imprisoned as a debtor and having their right to access medical care denied as well. And on so many scores, fundamentally incompatible with lots of the SDGs. And one struggles to think of a worse example of being in breach of the Sustainable Development Goals. But as well, and I think this is a sign of the acceptance of this, sort of seeing quite extraordinary stories of where in some countries, I think this one might be Nigeria, of local politicians knowing that the hospitals have a number of detainees, often turning up in the run-up to elections with a bag of cash and sort of paying off the bills of a lot of people. And this being seen as a great sort of gesture, that they care about the population, and then bringing the media in to show how magnanimous they are in freeing people from the hospitals. And even seeing stories, say, of a governor's wife, the first lady of a state, being celebrated as a hero for rescuing people from hospitals, actually run by her husband. But no irony at all in the coverage. Here's another example from Ghana. This was only last year, about a year ago, of Vodafone, the telephone company, paying off the debts of 108 patients held because they can't pay their hospital bills, and Vodafone using their PR machinery to celebrate that. Another shocking story, again, this is within the last 2 years, of a man trying to smuggle his newborn baby out of a hospital in a hold-all bag and being caught because they hadn't paid the bills, and ending up in court. And I think he ended up with a suspended sentence for having done this. So just quite extraordinary stories that we would all find so shocking. And a really, really ghastly story that I'm afraid to finish with this in this section, that, of course, the other side of this, if people don't get into the hospitals because they're denied treatment, and this one's from Cameroon, a shocking story of a woman who was in desperate need of a cesarean section to deliver her 2 twins, not being allowed in, and her relative trying to perform the operation on the steps of on the walkway to the hospital there, and her dying and the baby's dying as well. And this actually resulted in a riot in Cameroon, with the population being so outraged by this, which I'm sure everyone can imagine. But this is what we're dealing with these health financing policies. So this is clearly truly a dreadful state of affairs, and people sort of, what one needs to ask, well, who's responsible for this? And I would say that there are 3 main groups of people. First of all, the health workers and the hospital authorities, that it is totally unacceptable to lock people up, to chain people to beds, and that last case in Cameroon, let people die on the steps because they can't pay their bills. So there has to be some responsibility of the health workers concerned. But they have to get paid, and that this is the manifestation of a poorly functioning health system. And one looks again at the national government's concerns, that allow this to happen, allow fees to be charged, and are clearly aware it's going on when they're turning up once in a while to release people from the hospitals that they manage. So I would say that the ministers of health, but also the heads of state in these countries, are aware that this is going on and are allowing it to continue, but yet they will turn up at the United Nations in September to celebrate their progress towards universal health coverage. But also, it's absolutely vital that we acknowledge that international development agencies have played their role in this fiasco as well, particularly with the health financing policies that they imposed on these countries going back sort of 30 or 40 years or so. And just to name names, it's the World Bank and the IMF through the structural adjustments programs that told countries that they should cut public expenditure and push the financing burden onto households, and that this was perfectly acceptable. And we've seen budget shares for health really sink across Africa as a result of that. But even initiatives like the Bamako Initiative, which was an attempt by WHO and UNICEF to somehow put a human face on these policies by introducing community health financing, having the community decide who should be exempt, who shouldn't be exempt. And this idea of having the community manage processes like this, particularly in West Africa, the Bamako Initiative really took root in West Africa, but it is in West Africa that we're seeing this as a particular problem. So I think that we need to all recognize, the role of the international community in this, and also continuing with ineffective and inequitable health insurance schemes that often exclude vulnerable groups. Ghana, for example, when it launched the National Health Insurance Program in 2003, initially excluded pregnant women from the automatic beneficiaries. And we saw institutional deliveries go down 35% as a result of that. Thankfully, they reversed that policy now, and all pregnant women are automatically covered. But so don't let it be said that this is just these governments and the people working in these health facilities. I think we all need to look at ourselves in this respect. And really to bring you up to date, to show you how this is continuing. After our report, some very good investigative journalism was done, particularly by Maria Cheng, who went to Congo and visited health facilities. She visited 20 hospitals in Lubumbashi and found 19 of them were detaining patients. And outraged by what she found, she then challenged the donors in Congo around this, and was sort of finding some pretending to turn a blind eye to it, didn't know it was happening. But when she challenged the likes of the Global Fund about this, and initially their response was, oh, we don't really think this is happening, she actually got hold of the memorandum of understanding that the Global Fund has with the government of Congo, which astonishingly has this statement in it that medical detentions are only to be used as a last resort. So I would think that's pretty damning evidence that the Global Fund is fully aware that this is happening in Congo and is continuing to this day. So obviously this is a dreadful state of affairs, and we'll go on in a moment to discuss how particularly terrible this is with COVID-19 threatening health systems and hospitals in this part of the world. But, you know, what are the policy recommendations for this? Now, here I would suggest it is really, really straightforward. I mean, a lot of health systems and health systems reforms, one can say it's quite complicated and difficult. This isn't difficult at all. Heads of state in all these countries should ban medical detentions instantaneously. There's no justification for this whatsoever. And as we've seen, Burundi, one of the poorest countries of the world, the president did this pretty much the moment he was made aware it was happening in his hospitals. Likewise, the president of Turkey, in launching universal health reforms about 12, 15 years ago, there were even these detentions happening in Turkish hospitals. And as a real sign of action, the president launched his health reforms through banning medical detentions. So this is something that can be done in pretty much every country where this is happening overnight, I would suggest. But this doesn't tackle the problem of how are you going to pay the health workers and run the health facilities. And that's why it's very important to also combine this with health financing reforms that replace the user fees income with public financing. And again, this is what Turkey did, that Burundi did as well. And it's very much part of this initiative to implement universal health coverage reforms and particular financing reforms associated with that. So to sort of put this in the context of the debate about universal health coverage, and just reminding people, by universal health coverage, we're talking about all people receiving the quality health services they need without suffering financial hardship. And this being an SDG target, 3.8, is this target. Every country has signed up to this. So this isn't something that's being imposed on countries. They've agreed to this themselves. And this universal health coverage, with it being universal, everyone getting this without financial hardship, automatically means that we're talking about an equitable system where healthy, wealthy people must subsidize the sick and the poor. And in terms of health financing, there's no getting away from it. You know, this is the consensus around health financing for universal health coverage, that a market-driven, privately financed health system where people buy and sell services like they would buy other services will never result in universal health coverage. And in that situation, it will only be the rich who would be able to afford cesarean sections and surgical procedures, and the poor won't be able to get them. So there's a big role for the state in forcing healthy, wealthy people to cross-subsidize the sick and the poor. And this has profound implications for different financing mechanisms. Now, clearly, the worst way that you can finance a health system, which is the market-driven approach, obviously, is through user fees. Now, 30 years ago, the World Bank were promoting, in fact, imposing healthcare user fees on countries. But that changed, particularly under Jim Kim, with him saying at the World Health Assembly now that user fees are unjust and unnecessary. And my goodness, we definitely see the unjust part of that when it comes to hospital detentions. But also private voluntary insurance will not take you to universal health coverage either, because of the big market failures and there being real evidence of even community-based health insurance in sub-Saharan Africa being ineffective, inefficient, and inequitable. And a lot of those countries we've been discussing, they have community health insurance schemes that have been failing. And really, it's only public financing will bring you towards universal health coverage. A point made very forcibly by Grohol and Brundtland at the United Nations last September, when she said, if there's one lesson the world has learnt, it is you can only reach UHC through public financing. But the good news is, I think that research and activism is bringing about results. After we published our report, some Kenyan MPs and lawyers, in fact, lawyers defending that poor guy who tried to smuggle the baby out in the bag, we're very much sort of taken to this government saying this is unacceptable, and those videos, I think, have helped as well. And Kenyatta National Hospital, in fact, last year released 250 patients in one day, partly as a result of all this pressure. And also, the president now is launching publicly financed universal health coverage reforms, starting off in 4 pilot counties. And in these pilot counties, they've simply scrapped healthcare user fees, increased public financing to replace that income. And interestingly, at the beginning of last year, I visited one of the counties that's just implemented these reforms. It was launched on Independence Day at the end of December in 2018. And when I asked the in charge of a relatively small hospital what happened the very first day that you scrapped healthcare user fees, he said, oh, it was really great that we were able to release 9 patients we were detaining. We just rang up their families and said that they could come and get them. And there were only about 20 beds in the hospital anyway. So again, just doing the sums, you can see this remains a big problem in Kenya, and I'm sure in a number of other countries too. So bringing it right up to date and thinking about COVID-19 and some very, very worrying figures now about the impact this is likely to be having on developing countries with weak health systems, particularly in sub-Saharan Africa. I mean, it's just beyond belief that just as hospitals should be preparing for big increases of patients coming in requiring life-saving treatment, that a number of the beds are occupied by people who are perfectly healthy at the moment and really should be at home with their loved ones, but being locked up because they can't pay their bills. So, I mean, this is obviously a dreadful state of affairs, and that, you know, were the hospitals to become full of people with the coronavirus, you know, these healthy people would be at risk of becoming infected. But we are seeing now that this the COVID-19 outbreak is increasing pressure on governments to ensure everyone gets the services they need, preventive and promotive and curative as well, and is putting pressure on governments to socialize the health financing system. We've seen in Ireland and in Spain, in effect, at least on a temporary basis, the private health sector being nationalized to create extra space. And of course, even in the United States, I'm sure a number of people participating might have views on whether this is going to accelerate progress towards universal health coverage in the United States. So these are very challenging times, and it would strike me, you know, the most obvious thing that a politician in any of these countries could do to free up space and demonstrate that they're taking this seriously would be to immediately ban medical detentions in their hospitals. And so, let's hope that, you know, this might be one of the few positive outcomes of this outbreak, and we'll see this action being taken in the near future. So that's basically my slides. And just to say that if you're interested in this topic and universal health coverage in general, please feel free to follow me on Twitter. There's my handle at the bottom there. And I tweet about these things using these Google alerts pretty much on a daily basis. So happy to take questions, but through Twitter, don't forget, not with the hands up feature, and look forward to our discussions. Thank you very much. Thank you.
That was really great, Rob. Thank you very much. I do have a few questions from Twitter and a few initial clarifying questions. The first clarifying question seems to be obvious. Doesn't it cost these hospitals money? So why would they detain them instead of tracking them down for payment?
Yes, well, you would think it would cost them a lot, but sadly, in terms of their recurrent costs, it doesn't cost them that much at all. I mean, if they have people sort of locked up at, in a ward at the back on mattresses, And a lot of these people aren't receiving food. Their relatives are bringing them food. They're not getting medical treatment. So the marginal cost of keeping them there is actually quite low. But the bills that they'd be presented with are really very high, you know, sort of $100, $200. And they even increase those bills while they're there. And they make the calculation, the cost benefit to them. Yeah. Yes, exactly. Yeah.
So, and also it may not be clear to all of our audience that much of this has to do with blood for cesarean sections or trauma surgery. And you can't tell before you have a delivery whether you're going to need a cesarean. So it's sort of akin to surprise medical billing that we'll talk about in the United States context.
Oh, yes, definitely. And I think that, and of course, this is the tragic situation that people, knowing that this happens, delay and delay and delay going to hospital until it's very, very late. And then people are absolutely desperate. And I think we'll often be making promises that they can pay the bill, whatever, which of course you would do. And then, you know, it's like gangster style financing, you know, that, you know, people, it's your money or your life, and people being hit with bills, often not based off any costings or anything like that. So I think it literally will be a case of, you know, the in charge will say, well, we'll charge this one $200, this one $300, and then sort of taking it from there.
Now I want to turn to a question from Twitter about the user fees. Question about whether, do you believe there's a direct relationship between user fees in the broader context of the healthcare system and privatization tendencies and hospital detention practices? Is that an underlying driver?
Quite definitely, because, you know, this is perhaps the most extreme example of how bad, you know, healthcare user fees can be, you know, and I'd say that it's really quite shocking to see and I've seen it myself. I lived in Congo for a little while, of sort of really desperate people turning up, and the health workers not really getting any funding whatsoever from the government, thinking, right, this is an opportunity to make a lot of money here. In Congo, I remember there was a survey. People were asked which sort of public services they felt were exploiting them the most and they were most fearful of. And first of all, it was the army, then it was the police, and then it was health workers, you know, sort of people seeing health workers as being sort of really sort of quite rapacious in taking money off people. So it's really truly shocking to see this happening. But you know, again, I think this is a feature of a health system that where private financing like this is, you know, allowed to run rampant, and there aren't the accountability mechanisms to stop it.
And I want to follow up on that, because in global health and in many of these countries, I lived in East Africa for a number of years, there was a push for them to exempt pregnant women and under 5 children from user fees. And national governments did that in many cases, Kenya being one of them. But Kenya has a decentralized government and a decentralized health system. And as a matter of fact, the 47 counties pay for the services. So when the national government said, oh, mama kits are free and deliveries are free, when women showed up to their health services in different counties, that was not the case. So financing, the leverages of financing and the drivers of this seem somewhat more complicated.
Yes, and I think, again, it really shows, yes, that a sort of declaration that services are just free and everything's fine isn't good enough. You know, that clearly the public financing must be available to pay the health workers, to pay the medicines, to pay for the mama kits. And, you know, I think you're absolutely right. You know, we have seen countries like Uganda, where I was working, where initially there was this great optimism and surge of demand when the services were free. But you've seen the health budget share sink in Uganda, and one's very aware of big shortages of medicines and people having to buy key inputs like that. So it's not good enough, you know, just to sort of make, you know, these calls for exemptions, and particularly where there aren't the governance mechanisms in place. to sort of check on this, and people being charged under the table. And what's proved particularly ineffective is any notion of exempting people because they're poor. That just doesn't work at all. You know, I think a view of a lot of the health workers is that so many people are poor around here. Why should we make an exception for you? And you see very, very low levels of exemption based on that. I think it has tended to be a bit more successful when it's come to identifying groups like pregnant women and children. And I would say that some countries have done a better job of that than others, you know, particularly Tanzania and Malawi and you know, generally in East Africa. But I'd say where the Bamako initiative really took root in West Africa, and there was this total acceptance that everyone should pay the user fees, and if anyone's going to be exempt, it will be done by the local community. That patently hasn't worked at all. And you know, that it's particularly in West Africa where I think, you know, that the phenomenon of rampant user fees and medical detentions is worse.
And so I know that time is short. I want to ask you a last question about coronavirus. Mm-hmm. We've seen the kind of stresses and the kind of social X-ray that it puts on health systems, even in well-equipped and well-resourced health systems and contexts in the North. Mm-hmm. Where it really illuminates social fragmentation and inequities, both in access to care and testing and social determinants. But in low resource contexts where, as you said, it would be absurd to have these women detained when facilities are needed to treat COVID-19 patients, what might we be on the lookout for, and what is the responsibility of the international community to try to mitigate or intervene?
Yes, well, obviously, I mean, this is hugely worrying. Some of the numbers I've heard today about, you know, the projected death toll worldwide, particularly in developing countries, are truly, truly ghastly. And what you're really looking for now, you know, is true leadership from the heads of state to recognize that they do need to invest massively in their health systems very quickly, training community health workers, a very much primary healthcare led approach, making things truly universal, no user fees, contact tracing, doing all the, you know, the things by the book, the right way. And I think that one can see that some countries in sub-Saharan Africa, I think, are going to be able to do that better than others. I think, you know, the investment in the health system in Rwanda with a big number of community health workers, in Ethiopia as well, in Liberia too. You feel that there's a seriousness there to really ramp up universal reforms. And as I saw in Uganda back in 2001, by doing things like increasing health workers' salaries dramatically, buying lots of medicines and commodities, you can actually do a lot very, very quickly. And I think, you know, this is the urgency, but it has to come from the head of state. I mean, this is a head of state issue. It goes way beyond the Ministry of Health and the Ministry of Finance. The head of state has to take a grip of this, and the international community need to pour a lot of money in, particularly into low-income countries. You know, there needs to be whole-scale debt forgiveness as well. But I think, you know, the measures themselves are relatively straightforward. But what it takes is A, political commitment, and B, public financing.
And do you think there will be an appetite for international assistance to help underwrite efforts in low resource contexts to get their health systems up to speed, given that this is really a global pandemic?
Sure, and I think it's going to vary from country to country. I mean, one would like to think that there are some countries now that are an income level that this could be the time that they launch predominantly domestically financed reforms. I mean, we saw, for example, Thailand immediately after the Asian financial crisis in 2002 launched some of the most successful universal health coverage reforms we've seen. Sri Lanka did this back in the 1930s after a massive malaria epidemic. They hugely scaled up the supply of hospital beds. So I think some countries, and you know, I'm thinking particularly countries like South Africa, this is a great opportunity, I would say, for President Ramaphosa to create a truly national health system where the wealthy subsidize the poor. And, you know, that there are countries that you feel could really run with this, maybe with only limited amounts of international assistance. But then weak economies, you know, thinking of Sierra Leone, Liberia, you know, places like that, they are undoubtedly going to need big injections of public financing, but that coming externally.
Well, let's hope that this crisis does provide an opportunity for moving toward publicly financed universal health coverage. I'll turn it back over to my colleague, Carmel Shahar, and thank you so much, Rob, for sharing your thoughts today.
Fantastic. And I'll be staying on the line if there are any more questions.
Wonderful.
Great.
Thank you, Ali. Thank you, Rob. We are now going to turn the focus of the day from Africa to the US, because these issues don't just affect people over there, as Ali mentioned in her introduction, but these structural issues affect people in the US as well. Joining us today to discuss the issue of debt in the American healthcare system are two journalists. We will first have Wendy C. Thomas, who is editor, MLK 50, Justice Through Journalism, as well as the investigator reporter of a fantastic series, Profiting from the Poor Inside Memphis Debt Machine, which was produced in partnership with ProPublica. I highly recommend that you read it. We've linked to it on our events page. Also joining us will be Jay Hancock, who is a senior correspondent at Kaiser Health News and contributor to Kaiser Health News' investigation of the University of Virginia health system's very aggressive billing practices. We are going to first turn it over to Wendy for her remarks, then to Jay, then we will have some time for moderated Q&A. As a reminder, please don't use the raising your hand function in Zoom. Instead, join us on Twitter under the hashtag #DebtDignityHealth. If you post the questions there, I will be reading them and I will be funneling them to Jay and to Wendy.
Hi.
All right, Wendy, the floor is yours.
Okay, great. It's good to be with y'all. Today, I'm going to share my screen, start with my slides. So as was said, I am the editor of MLK 50, Justice Through Journalism. We're a nonprofit newsroom based in Memphis, Tennessee, and our focus is poverty, power, and policy. We're almost 3 years old, and we, as our name suggests, we draw inspiration from Dr. Martin Luther King and his vision of economic justice. As you know, he came to Memphis in 1968 to support underpaid workers, specifically Black sanitation workers, and he gave his life for that cause here in Memphis. And so MLK 50, Justice Through Journalism, we center the people that Dr. King would center were he still alive. And so the investigation that I'm going to talk about started with kind of a central question. Why is Memphis so poor? So some context for those of you who maybe are not as familiar with Memphis. Memphis is the second poorest large city in the nation. More than 1 in 4 residents here live below the poverty line, and more than 40% of workers earn less than $15 an hour. Now, part of the answer to the question of why Memphis is so poor is that we have a predominance of poverty wage jobs in low-paying industries like distribution and logistics. FedEx is headquartered here, as are a lot of other warehouse and warehouse-adjacent companies. Actually, the cheap labor in Memphis has actually been billed as a selling point. And so as recently as 2017, the Memphis Chamber of Commerce bragged that wage rates here in Memphis, there was a workforce available at wage rates that are lower than most other parts of the country. This is 2017, how the Chamber of Commerce was marketing Memphis. And so when we talk about poverty, there's really a simple solution. If you have more money, you're not poor, period. And so often when we look at poverty, though, we think about the money coming into the households. But this investigation, Profiting from the Poor, looked at the money that was being siphoned out of households. And so that led us to Methodist Le Bonheur Healthcare. It's the largest nonprofit healthcare system, actually the largest healthcare system, period, in the Memphis area. And what we found by reviewing Shelby County General Sessions Court records is that over a 5-year period, this nonprofit hospital, tax exempt, that this hospital system sued more than 8,300 people. Many of them were low income. And so we started to investigate this hospital system's truly rapacious debt collection practices that were throwing already financially precarious lives into chaos. We discovered that this faith-based institution, whose motto is that they're committed to a culture of compassion, had become the most aggressive plaintiff, suing patients over unpaid debts in the county. And now hospitals across the country sue patients for unpaid hospital bills, but few are doing so in a city as impoverished as Memphis. So week after week, for 5 months, I sat in General Sessions Court listening to the cases of hundreds of defendants as they faced the hospital's own collection agency, which is a bit unusual for a hospital to own its own collection agency. These defendants were encountering stern judges, often didn't seem to have a lot of understanding for the financial challenges these defendants were facing. And the system itself, often pitted these defendants, who almost never were represented by attorneys themselves, and often were confused about the process, against Methodist savvy legal team. And there at the desk is one of Methodist lawyers, and you can see all the stacks of cases that he was going through. So one of the defendants I met in court is Carrie Barrett. You can see her here. And she's a grocery store clerk who made $9.05 an hour. And she had been sued by the hospital for about a $12,000 hospital bill, but thanks to interest and attorney's fees, the bill had swelled to more than $33,000. If Ms. Carey paid on her overdue hospital bill as the court had ordered, she would be 90 years old by the time she satisfied her debt. Some of the other defendants that I ran into in court were actually wearing a Methodist hospital uniform. So yes, this hospital was suing its own employees. This is one of the employees that we talked to, and we granted her anonymity because she was worried that the hospital would fire her for talking to a reporter about her lawsuit. And when we actually asked the hospital if that was a valid concern, they refused to answer that question. This housekeeper had been sued and owed more than $23,000 to the hospital. It was more than she made in the prior year. I spent a lot of time with this housekeeper, and I asked her how she was making her ends meet, and she said she doesn't. She'd taken out payday loans, as had Miss Carey, to pay the hospital to try to keep her wages from being garnished. And she told me, quote, "It's killing me softly," close quote. The small monthly payments that some of these defendants could make were drowned by the mountains of court costs and interest. The hospital just routinely added 5% of the hospital bill. No, 33%, I'm sorry, 33% of the hospital bill was automatically added to the case as attorney's fees. I talked to defendants who turned to payday loans, another one who made her payment to the hospital and then her car was repossessed. She had 4 children under the age of 5. There was another woman I talked to who had been sued over her son's hospital bills, and she was skipping her son's follow-up appointments with a heart specialist because she couldn't afford them. So not only was Methodist really aggressive in court, its financial assistance policy was stingy compared to other hospitals across the state. You know, as we reported this story, of course, I talked to a lot of experts, I guess I should say formal experts, because the lived experience of these defendants is also an expertise. But consumer advocates that I talked to, you know, noted that suing patients is a choice. And it's a choice that many nonprofit hospitals have decided not to make. I talked to a retired Methodist minister about these practices, particularly indebtedness that the employees had to their employer. And he called that a 21st century version of slavery. So with all investigative stories, you're looking to see who is responsible and who has the power to change. And so these are the pictures of Methodist Le Bonheur Healthcare's board members. I reached out to just about all of them for the story, and none of them would go on the record and comment. Most of them ignored my emails and calls altogether. And so these were people who had the power to change this, and for whatever reason, didn't. So after we ran this story, within 5 days, the hospital suspended all its court collection activities against defendants. It embarked on a 30-day review period. It pronounced itself humbled, as you'll see here, and announced a series of sweeping changes. Those changes included offering financial assistance to uninsured patients earning up to 250% of the federal poverty line. The previous policy applied to patients only with income up to 125% of the federal poverty line. And so this increased, more generous financial assistance policy covers families of 3 that made have a household income of at least just over $53,000 a year. The hospital also announced that it was not going to sue anyone whose household income was less than 250% of the federal poverty line, and it wasn't going to sue its own employees at all anymore. The new threshold that the hospital set for its financial assistance policy covers more than 50% of residents in the Memphis metro area. One of the changes that I didn't anticipate, and that is something that I hope Dr. King would be proud of, is that the hospital announced that it was increasing the pay of its lowest paid workers from $10 an hour to $13.50 an hour in September. So this was this past September that this took place, and that the hospital was also going to increase the wages further to $15 an hour by 2021. The pay increase that took place in September 2019 boosted the pay for an estimated 2,000 employees. And so that's good news. We wanted to determine, so after the hospital announced these changes, I'm still going to court, and I start to notice that case satisfied notices are being filed with the court. And these are just notices that tell the court that the balance owed is 0. And we were able to determine that the hospital was dropping cases by the hundreds, by the thousands. And I asked them, the hospital never, I should say, never throughout this whole investigation would make anyone available for an interview at all, stonewalled all attempts. And even when they started erasing these debts, would not tell me how much. So I hired a team of researchers, and they looked up one by one more than 5,300 cases in the online court records. And what we were able to report was that the hospital had erased at least $11.9 million for more than 5,300 defendants. And we featured some of those stories here. This is the kind of reporting, and this is the kind of impact that investigative reporters dream of. I would be remiss if I didn't say that I'm grateful to the women, and most of them were Black women who trusted me with their stories. The data is one thing, and that's great and it's essential, but they were brave enough to come forward, to set aside the shame that a lot of people have connected to debt and share their experiences. And because of that, you know, their courage, you know, measurably improved the lives of thousands of residents and thousands more who will not be sued for hospital bills that they can't afford. And so I'll just end with a few thoughts about coronavirus, kind of bringing this into the current moment. In Memphis, here in Shelby County, we have 198 confirmed cases and no deaths at this time. But if you look at the rate, the increase, it's a steep curve. The city and the county have a shelter-in-place order that is generally being disregarded based on what we're seeing in public parks, where kids are climbing all over the playground and the 6 feet social distancing is not being adhered to. And the shelter-in-place orders only went into effect Tuesday and Wednesday of this week. And so I've talked to the CEO of one local hospital system, and what they're telling me about testing and treatment and the bills is not particularly encouraging, particularly in a community where we have more people, a higher percentage of people who are uninsured, a higher percentage of people who work in low-wage industries where they've been deemed essential, like warehouse, grocery stores, but they're not paid as if they're essential. And I think this coronavirus is just heightening our awareness of how stacked the system is against low-income people and low-income workers. And so if you can get a test in Shelby County, if you meet the guidelines and you can get an appointment at one of the public testing sites, and a large one is supposed to be open as early as Saturday, those tests will be free. But if you go to one of the hospitals, you could be charged more than $300, and that'll be, first they're going to screen you for flu, then they're going to give you the respiratory virus panel, and lastly, you could get the COVID-19 test. I asked this one hospital administrator, you know, what is the message for people who may be symptomatic or worry that they were exposed, but are reluctant to get, you know, come to the hospital for any kind of evaluation for fear of the bill? And he told me that they're holding the bills for now. So not, you know, not erasing them, but just holding them in hopes that the federal government is going to send some kind of relief or funds to hospitals. But he said that if they don't, the hospitals don't get that, then they will proceed as they typically do to, you know, pursue recouping those costs from patients. And so I haven't seen a strong public health message here locally that people should put their health first and that they will not be burdened with undue costs because of this. And that concerns me. I think the vulnerable people are, again, the most vulnerable and maybe overlooked in this moment. And I think it's just it's an opportunity for journalists to be vigilant, and I know MLK 50 will be doing that, as you know, we're thinking about poverty and power and policy and how those intersect in communities like Memphis. So I will stop my share and stop talking and let Carmel guide us from here.
Thanks, Wendy. So Jay, you are up now.
Let me get my my shared content up here. And that is not what I want to share. Let me make sure my Okay, can you guys see that?
Yes, we can.
All right, good. So we'll just go through this pretty quickly here. There were it was kind of a golden moment for investigative hospital bill journalism last year. There were multiple exposés on horrible practices by respected healthcare institutions. Wendy's was one. We got a tip in 2018 that University of Virginia Medical Center and its affiliated hospitals were engaging in this kind of behavior. We looked at it. It proved out to be just beyond anything that we might have imagined. I want to introduce you to a few patients here that are by no means atypical of UVA patients or atypical of the abuse that was going on. This is Mr. Williams. He had a sore throat. He goes to the emergency department. He's uninsured. He knows he has to pay cash, but he figures they have doctors at the ED, and how much could a sore throat cost? They give him a CAT scan. They bill him for $7,000, and we engaged consultants and analysts to look at a lot of these bills because a lot of you are going to be familiar with the hospital charge master, which is the list prices that hospitals use. They're completely, I don't think it goes too far to say they're inflated charges. And they're generally the starting point for negotiations with insurance companies. Hardly anybody pays them, and yet underinsured and uninsured patients are billed at rates linked to the charge master, which is one of the underappreciated outrages of what goes on here. And our experts found that a commercial insurer would have paid $992 for Mr. Williams's treatment. He got sued. He ended up in court, like many others we found. Ms. Davis is married to Hardy's cook. She herself is disabled. She has severe back pain. She had treatments at UVA previously that were approved by her insurance. The prior authorization, for some reason, was not obtained this time. She went, she got the treatments, $7,500 bill. It really, that was far more than it cost UVA. Commercial insurer would have paid $3,500. Heather Harmon and her husband are insurance agents. They understand, they're health insurance agents. They understand healthcare, yet they wound up through a glitch through healthcare.gov without insurance a couple years ago. She had really severe internal malformations of her intestines, spent weeks in the hospital. They lost everything, their house, they had to move, they got divorced. UVA's bill and lawsuit was for $160,000. That was twice what insurance would have paid, and yet UVA went after her for this ridiculously huge amount. This is another outrageous case, maybe the most outrageous. Mike Miller and his wife Kit, they lost a house to UVA in the early 2000s. They basically lost all the home equity that they built up in a previous house that they'd had. They've got a different house now. There's a lien on it from a UVA lawsuit for $193,000. They're worried about losing a second house to their caring nonprofit regional medical center. The commercial insurance would have paid for the radiation that Mike received $13,000, and yet he's facing a bill for $193,000 and the prospect of losing his house. So we looked at thousands of suits like this, UVA as well as VCU Health. These are the two prestige teaching medical centers and their affiliate hospitals in Virginia. Massive lawsuit machine, 36,000 lawsuits over 6 years for UVA, 56,000 for VCU Health. We added up the dollar amounts. UVA was suing for $106 million over that period. VCU for a little bit less. One of the things we found, like Wendy, is that these institutions had crap charity care policies to the point where they not only had an income test, but they had an asset test. They look at how many cars you have, they look at your house, and they looked at your retirement accounts. If you had a few $1,000s in a 401k account, which is pretty much exempt from almost any creditor action in most cases, that flunked you to qualify for UVA's financial assistance. And so you had people like Ms. Davis, whose husband had $6,000 in a Hardee's 401k account. They didn't qualify for financial assistance. They got sued. They landed in court. That's where I met her. Also disqualifying if you have a house on more than 4 acres. You know, they let you keep your primary home, but they think if you have more than 4 acres in these rural, you know, lower income places that you're too rich to qualify for assistance. They were garnishing wages, you know, in thousands of cases, taking wages, including, you know, lots of low income folks, Walmart employees. They're seizing your tax refunds without a court process. They don't need to go to court to garnish your wages because UVA and VCU are state agencies, and the state agencies in Virginia have a set-off thing where they can trade off if they say they're owed. They don't even need to prove it in court. And lastly, thousands of property liens placed on people's homes that they've worked for all their lives. Here's our heat map of where the lawsuits were going on. This is Central Virginia, Piedmont, Virginia, not technically part of Appalachia, but not a super high income area either. We encountered lots and lots of families with few assets, properties that they may have inherited and that were now encumbered by these UVA liens. These institutions that were doing this behavior are massive, respected, and probably the most politically powerful institutions in the state of Virginia. UVA Health itself takes in about $1.8 billion in annual revenue. This is just the health aspect, mind you, not the university. They made $500 million in profit over 6 years. This is a state agency, but this is profit by any measure. It's net income, it's money in their bank accounts, and that's not even counting transfers that they make to the University of Virginia academic part. So this is a massively profitable institutions. They own stocks, bonds, and other investments worth $1 billion. They are not, you know, they're well in a position to take care of their community, and they are not. They're doing the opposite. In many ways, they are abusing their local community, and they're actually inflating what they claim was their charity care for their community. On their books and in their press releases, they say, oh, we gave out $300 million in charity care last year. Again, this was based on the charge master, which is not a real charge. It was not counting money that they get from the federal government and the state government that's earmarked to pay for lower income care. The actual cost to UVA, to this vastly wealthy institution for charity care in the most recent year we looked at, was $4 million. Many would argue that that was not doing their share. One of the interesting dynamics here was getting people to speak on the record, as Wendy found. And we really felt strongly that the doctors delivering this care ought to have something to say about this. And as you might expect, we had lots of challenges that way. UVA and VCU, you know, like any university system, are hugely political. Doctors worried about speaking out. We tried and tried and tried. And eventually, a few courageous doctors stepped forward. Some wrote a letter to the editor and really, you know, made the moral choice to call this out for what it was, which is behavior that was deplorable and not in keeping with the express mission statement of UVA Health, and certainly not in keeping with the Hippocratic oath that the doctors took to do no harm. They felt betrayed by what the medical center was doing. They were unaware of really what was going on, as were a lot of people. This was a huge sort of mechanical, bureaucratic operation that had been going for decades on its own momentum that nobody really had the big picture of until we wrote our pieces. We got reforms too. When you embarrass institutions like this, like Wendy did, they have no choice but to step forward. And we were gratified to see some change so far, and hoping for further change. UVA, which was suing everybody, we found bills, we found lawsuits for UVA debt for as low as $14. They're now promising to stop suing people below 400% of poverty guidelines, excuse me. VCU is halting all patient lawsuits, which is really gratifying. They're still going to go to collections. They're still going to try to collect the money. They just are saying they will not take the last drastic step to use the legal system to seize your assets if you don't pay up. We were super happy to see that VCU is going to take a year and go to every courthouse in Virginia to remove judgment liens from patient property. These are really insidious, really harmful legal instruments that take away what people have worked a lifetime to accumulate. They can sit there for decades in the court record, and when you go to sell your house, UVA will take all the equity that you built up, even if you paid off the mortgage company. Both systems increased financial assistance. UVA increased the threshold for their asset test to $50,000, which in my case is still pretty low, and they're still including retirement funds for your asset test. We're hoping that there will be further change. UVA convened a community group composed of community leaders and UVA officials to consider further changes, and they're going to announce things this summer, and we hope that getting rid of property liens will be part of that process. This goes on everywhere. One of the follow-up stories we did was looking at the American Hospital Association, and just as sort of a slice, random but still representative slice of the hospital industry in the United States, particularly nonprofit hospitals. This guy, Brian Grandliotti, is CEO of Atlantic Health System in northern New Jersey. He is the chairman, or he was until this year, the chairman of the board of the American Hospital Association. Mr. Grandliotti's health system has been suing debtor patient families at a rate of even greater than UVA and VCU. One of the families was the Meakin family, whom I talked to, and NBC News later did a follow-up on. Tricia Meakin and has 4 sons. 3 of them have cystic fibrosis. Their local hospital is Morristown Medical Center, run by Mr. Grandliotti. They struggle to pay for bills. The mom works 2 jobs to pay for all this. They get sued and sued again by Mr. Grandliotti's health system. We looked at the financial assistance policies of all the hospitals represented on the AHA's board, and basically what this is telling you is that there are no national standards for financial assistance. The Affordable Care Act was supposed to increase oversight and standards for nonprofit hospitals in terms of their charity care and their community mission. In reality, there are no standards for financial assistance. They're extremely squishy. Hospitals claim that a lot of things they do qualify for community assistance, and they can pretty much do anything they want in terms of financial assistance. And this shows just the enormous spread in the practices that hospitals do and the leeway that they have to set their own policies. Why did this happen? And I have to say, after watching Rob's presentation, I'm just amazed and shocked at the parallels of what Wendy and I found are with what Rob is seeing in Africa. I mean, even some of the language is the same. UVA told us that they only sue patients as a last resort. Well, as Rob said, imprisonment is only the last resort by the medical institutions in Africa. You know, we really don't want to do it, but we have to, and if we want to get paid. And I just was struck by the parallels. Why is it going on here, one of the richest countries in the world? It's our fee-for-service medical system where hospitals bill for procedures and what they get paid. It's the private medical system. It's the lack of universal coverage. It is patchwork insurance coverage. So what was interesting is a lot of the patients we spoke to were uninsured, like Mr. Williams. A remarkable amount of folks had insurance. They had insurance plans. They did the right thing. They went out, they bought a plan, and they still got sued by UVA medical system. Why? They were out of network. Their insurance was inadequate. They bought some of these indemnity plans that only cover specific procedures that they didn't understand. So even when folks were insured, or they had huge deductibles, a lot of plans now come with, you know, they don't kick in until you pay the first $4,000 or $5,000. Who has that sitting around? You get sued by UVA Medical Center. So, you know, even, you know, we can public officials can say in this country, oh, you know, the Affordable Care Act, you know, means that whatever it is, 80% of Americans, 85% are now have health insurance. Well, actually they don't if they end up in situations like this. Narrow networks are another problem. One of my theories is that part of this has to do with the Emergency Medical Treatment and Active Labor Act, which was passed years ago to require hospitals to treat everybody in an emergency situation. And one of the things that it did was it trained hospitals not to talk about cost as a patient presents at the hospital. They are, you know, they just have manuals, and they're, you know, their motto is, we treat everybody regardless of ability to pay. But then they say nothing about what happens after the treatment, which is where the real harm and a lot of the financial and psychological trauma happens. To close with, I'll mention COVID as well, because COVID patients, like, you know, other patients, despite the legislation that Congress is going to pass, are going to be vulnerable to these to this aggressive treatment by hospitals. Here's a case that I just took randomly off the news last week. $35,000 bill. The patient is hoping to get coverage, but is by no means guaranteed. She's going to have to wait for her insurance benefits to come in, and who knows, maybe a lawsuit later on by the hospital. So thank you again for listening. We were astonished by what hospitals are doing. This is by Methodist, Le Bonheur, and the Virginia medical systems are by no means exceptions. There is no way to tell how much this goes on nationwide. There's no database to show this. The state courts are really fragmented. It takes journalists like Wendy and me going in one courthouse at a time to see what's going on. And I assure you, this is going on everywhere. And I think we're going to, unfortunately, be seeing more and more stories about this. The hospitals are reforming one at a time. The American Hospital Association says it will re-examine its policies, but who knows what that means. So thank you for listening. And happy to take questions. And the next time you're near a hospital, be careful of what happens. Thank you.
Thanks, Jay. So I'm bringing Wendy back, and we're going to have now a little bit of a conversation. If you would mind ending your screen share so that people can see our faces. Great. So my first question, both you and Wendy have explained that embarrassing or shaming hospitals does seem to have an effect, but that's obviously ad hoc. That depends on the existence of a Jay or a Wendy looking at a hospital. What would you recommend as a more systematic way to address this problem?
Well, we felt strongly that the American Hospital Association was one systemic way of looking at this. Their their reaction was kind of lukewarm, and we'll see what happens. I think it would take federal legislation, really. Congress could step in and impose new, much stricter requirements on hospitals having eligibility for non-taxable status. They don't pay taxes, not only federally, but also locally, because the presumption is they're going to do good things for their communities. One thing Congress could do is make sure that they live up to that.
Yeah, I agree. I know Senator Chuck Grassley has been looking into this over the years and sent a letter to Methodists after our investigation was published, basically asking, in nicer terms, what the hell are y'all doing? And so he has, said publicly before, should there be asked, should these hospitals have tax exempt status if they're not providing a certain level of charity care? And honestly, and I think this is a shame, I think unless it's mandated, I'm not sure that they will, hospitals are going to take that step on their own. Should they have to, provide, an amount of charity care that's equal to the taxes they would have been paying, or some multiple order of that, I'm not sure, but without regulations, I would be shocked if the American Hospital Association or hospitals were to do it en masse voluntarily.
Some localities have stepped in a few states. I can't remember which ones they are. The states or maybe even the localities have stepped in and said, okay, you're exempt from property tax too. We're gonna, maybe not. You've got to do better here, or maybe we're going to start taxing you. But again, that's a one-off thing. It's not a one-button solution.
So my next question, I'll also open to Rob if he wants to join. What do we think the lasting impact of this treatment is on patients as they experience this from their caregivers, as well as years down the line?
Sorry, can you say again, come up?
Sure. So Rob, my question is, what do we think the lasting impacts of this treatment will be on patients?
Oh, I think that it's a that to be presented with bills like this and it totally traumatizes people. It plunges people into poverty, and I think as well completely discourages people from going anywhere near the health system. That it's as much that and it's not only the impact on the people themselves who experience it. The idea. I mean, sure, it's the same in the US, but also say in rural communities in Africa. If someone has experienced this, and word gets around the community that a hospital is behaving in this way, it massively discourages people from going. And, so they're much more likely to self-treat or to take herbal medicines or sort of go on the internet to try and find alternatives, which is really bad for their health and society's health as well. So I think that the impact on individuals and households and societies is much bigger than just the, you know, the sums that you're talking about. You know, it's really, really quite profound.
Yeah, I was going to hammer the point that Rob made. It makes people scared of the people who are supposed to take care of them, and they avoid the hospital. We talked to a woman in Central Virginia who broke her ankle, had UVA surgery. They did her ankle was continued to hurt. She continued to have problems. She couldn't walk well, and she said, I want to get it looked at, but I can't afford to go back.
Mm-hmm. Mm-hmm. And just to add to that, it's very interesting that when the architect of the British NHS, Nye Bevan, looked back on his successes in 1953, he named his pamphlet "In Place of Fear," and it was all around that taking the financial anxiety out of access healthcare had a profound impact on people's well-being. So it's not just the access to the healthcare, it's not just that people aren't plunged into poverty, it's just that people have that anxiety taken away from them. And speaking here from the UK, I mean, obviously, society is very frightened about COVID-19, but all of us know that if we need treatment, be that, just in a primary care setting, but even ending up in ITU for weeks and weeks and, having very expensive care, we'll get that and it won't cost us anything at all. And that's a really big relief.
So that actually leads into my next question. I think a theme throughout these presentations has been health systems that do not have universal coverage or nationalized health care. Do we think that this problem will always exist unless we move to a national or universalized healthcare system for these countries? Or do you think there's a way to still have a private healthcare system, a fee-for-service system, while addressing these concerns?
I'm not familiar enough with countries like the Netherlands or Switzerland where they have something that looks like universal coverage using a private system. It's my understanding there is private insurance in those places. And I just don't know whether this kind of legal activity goes on there. I would say that, I mean, no system is perfect, but the multiple layers that we have in the US, including the insurance companies, exacts sort of an administrative toll, a bureaucratic toll. It's really hard. I mean, one of the things that struck home for me in talking to people is just how hard the system is to navigate, and how they just don't feel equal to coping with these bills and these lawsuits. And I mean, the lawsuits are bad enough, but even before they get the bills come, the explanation of benefits come, and people have so many other things going on in their lives that they just don't, it's just not something that they can deal with, and that's a cost on their lives all by itself. Maybe Rob's more familiar with the international situation to say how, hybrid systems like the Netherlands work, but I'm not.
And yes, just coming there, I think that virtually all systems are actually hybrid systems when you think about it, of public and private. And here in the UK, you're quite at liberty, if you want to take out supplementary private health insurance. And about 7% of the population do. I mean, we don't, and none of my friends do, because we just don't really see the point of it. So thankfully, we have got this situation that everyone can fall back on the NHS. And other systems in Europe are sort of a mixture of compulsory social health insurance contributions and tax financing. But with then some people taking out voluntary private insurance instead, it might sort of get them better sort of hotel style accommodation, but not necessarily better healthcare. And that works fine. That works great. But it is absolutely vital that there is a universal publicly financed system to fall back on. And pretty much every country in the OECD, with the exception, and sadly, of the United States, but also, funnily enough, Ireland also hasn't really adopted a full UHC system yet. But I'm just wondering if that might happen now. You've seen the Irish government temporarily nationalise a lot of the private health sector in Ireland. So I wouldn't be surprised if one or two systems don't move that much faster to UHC as something as dreadful as COVID comes along.
My next question is related to current events. I believe that today the US has officially overtaken China and Italy as having the most diagnosed COVID cases. Wendy, Jay, do you think some of these medical debt collection practices had a hand in creating the situation where coronavirus spread so fast and so widely throughout the US?
I can take that. Wendy?
No, I'll let you take that. I'm not sure.
I would. It may have been a factor. I would point to two factors that probably had a greater effect. Certainly, one was the delay in getting test kits out here in the United States. That seems to be a really important variable in a lot of people's opinions. But I would also point out the thin and patchwork primary care healthcare system in the United States. You know, we've been focusing on hospitals, and you know, primary care is the step before the hospital, and particularly for lower income folks, for Medicaid, it's really, really inadequate. And I would point that up as another factor. But I would say if you've been taught to be scared of your healthcare providers, and if you're afraid that you're going to get a lawsuit if you seek care, then of course, you know, I'm quite certain that somewhere out there there is a COVID patient who delayed in seeking care because of uncertainty about the medical system. And just, you know, we should also mention that there's just a huge disconnect between lower income communities and people of color and the medical community in general. There's just a cultural disconnect, and folks are uncomfortable with the medical system for reasons that also have nothing to do with finances.
Yeah, I would echo that. I think that a lot of Black communities have distrust, and a justified distrust of the medical system. When you look at all the racial disparities in healthcare, I mean, things as basic as, you know, doctors believing that Black people don't feel pain as intensely as white people, and, you know, drugs being withheld because of that would treat their pain, address their pain. And so I think, you know, you could look at the Tuskegee experiment as well, and, you know, that resonates with a lot of people, and I think it makes them generally distrustful of medical professionals. And I haven't seen research around this, but I wouldn't be completely surprised if there was and more of an inclination maybe not to believe what's being said, because you feel like you can't trust officials anyway. Just a whole official narrative, maybe you're more skeptical of. And I understand that.
Wendy, Jay, you guys focused on some nonprofit health systems, which I think tells an important story about institutions that we think of as being charitable that might not be. Do you think that the practices of for-profit health systems when it comes to medical debt are different than nonprofit health systems, or do you think it's more of the same?
We didn't look super closely at for-profit systems. We did find in some cases that for-profit systems had policies that were superior to those of VCU and UVA. And I have an impression that's not based on data or thorough research, that they are typically not as aggressive litigiously as some of the nonprofit centers. But I just don't know. And they may be wary of bad publicity. What I can say is that we didn't find, and we looked at Virginia most closely, we did not find a lot of lawsuits from for-profit hospitals there.
Yeah, I think I would generally agree. You know, we did look at, evaluated the financial assistance policies of for-profit and nonprofit hospitals across Tennessee to see what the variation was. And there were some for-profit hospitals whose charity care policies were more generous, and a few that were not generous at all. So I think there is some variance, but we did not notice the number of lawsuits, or a significant number of lawsuits from for-profit hospitals. I will mention quickly another story we did last year in our investigation, which was into ER doctors groups, particularly one here called Southeastern Emergency Physicians that is owned by Team Health, which is connected to private equity. And so the rate of lawsuits paralleled private equity, Blackstone Group purchase of Team Health, and the number of lawsuits just soared after Blackstone took over Team Health or invested in Team Health. And so I think that Southeastern Emergency Physicians, they were aware of the stories that we'd done about Methodist. And before we were able, after we'd asked our questions before the story published, they said, you know what, we're not going to sue any patients either. They didn't want that smoke. They learned from Methodist's mistake of not communicating at all on Stonewall. And so that was another win. And that's something we haven't talked about, you know, a little bit like ambulance groups and doctors groups. They also sue patients for unpaid bills.
So before I turn this back over to Ali to summarize the day, I want to ask the three of you, if you had to tweet out one key takeaway for our audience on the topic of medical debt, what would that tweet be?
Maybe if I start, that medical debt is a violation of human rights, and the way to overcome it is through publicly financed universal health coverage.
I would say your local beloved nonprofit hospital and health system may not be living up to its high-minded mottos when it comes to dealing with its patients financially, and particularly its lower and middle income patients.
Yeah, I would echo that. I would say that when hospitals sue patients, that's a choice. That's a decision, and they could make better choices.
Very good.
All right, well, I would like to thank all of our speakers for their remarks. I'm now going to turn the floor back over to Ali, who will summarize the day and bring out a few structural themes on this issue.
Thanks, Carmel, and thanks very much for that panel, Jay and Wendy. One of the things that we wanted to do today, which I think has come across really well, is that sometimes in the United States we look at the problems we are facing in a very insular way, and we don't realize that there are similarities outside, but by learning about other places, it shines a new insight onto our own issues. And similarly, in global health, we often tend to look at things out there as what global health means. And I think today we've very much seen that global health happens in the United States too. I can't really say which of the two panels and the issues discussed I find more scandalous and outrageous, whether the detentions in facilities or the predatory debt collection in the richest country in the world. And I want to just touch upon a few points that may be self-evident, but I think are worth underscoring. One is that I think that visceral sense of indignation and injustice comes from the idea that health should not be treated like any other commodity. It's not like whether you pay for a first-class ticket or an economy ticket on an airplane and you just sit in a different place. It is fundamental to our dignity and our life plans. It's fundamental to allowing us to function as equal members of a social community and polity. And in both of these situations, it is the poorest and the most vulnerable and the most marginalized, and often with a significantly gendered and racialized dimension, especially, well, not especially here, with a significantly racialized dimension here and gendered all over. The second thing I want to highlight is UHC. You know, in this country, we talk about, there's been an increasing amount of mantras about health is a human right. If some Bernie Sanders and some of the Democratic candidates had gotten their way. But the world is now engaged on this issue of universal health coverage, which Rob talked about at some length. But universal health coverage requires, as he noted, fair financing, which requires solidarity and a large risk pool, so wealthy are subsidizing the poor. It requires priority setting, so perhaps not every service that everybody wants is going to be available immediately through a public system, but can be purchased by very wealthy people privately. And it requires reducing out-of-pocket costs, as he referred to in Africa, as is obvious in this debt collection by nonprofit hospitals here. It requires all of that in an explicit, transparent way in which people can understand how the health system works. I think one of the most evident things that has come through over and over again today is that health is really sort of a matter of the quality of our society and democracy, and health systems function just the way in this society in the United States, the criminal justice system really excludes racial minorities with a particularly disproportionate effect on men of color. The health system acts in a predatory, aggressive, exclusionary way with, I would say, a particular effect on women of color, although across the board for marginalized communities. And the last thing I'd say is that we can only hope that this COVID crisis, which is really revealing so many of the inequalities in social determinants of health in our society, in this gig economy where people are just laid off and don't have regular health insurance benefits, as well as across the world, the inequalities within societies and between societies, that it makes us wake up and think about health systems as functioning as social institutions and not just as technical delivery apparatuses for goods and services. Because we rarely in normal times think about our health. We only think about it when we get sick, and women think about it when they go to give birth and have reproductive or child health needs. So if there's anything that's positive that may come out of this crisis, it is that we start to rethink about the need for universal and equitable health systems as part of the fabric of our democracies. And I again want to thank all of the panelists as well as the Petrie-Flom Center for organizing logistically this very complicated event.
Thank you, Ali. With that, we are closing this event, but please keep an eye on our website. We have several live stream events planned in the works, some of them covering what's in the news today. And we look forward to seeing you on Zoom, even if we cannot see you in person. Thank you, everyone.